I understand the role of BRAF when we're thinking about targeted therapies on patients with anaplastic thyroid cancer. I think it's quite clear to me, but I still struggle. When should we check BRAF in clinical practice? You mentioned, Laura, that sometimes you actually have the BRAF results at the time of deciding for surgery or deciding for additional therapy with radioactive iodine. Is this because they are coming with molecular testing that have BRAF, or is because you are asking for it?
Not at all. We would never ask for genetic testing on nodal biopsies. You know, when people come with indeterminate nodules and they get a thyroid or an afirma or some tumor classifier outside, gene classifier outside, they just come with the result of the BRAF. But we honestly still use the BRAF when we are thinking of redifferentiation therapies. There is we don't plan, the surgeons don't plan the surgery differently. I don't think that they are at this point paying attention to the genetic component. If it's available, it might be an internal bias that they do have, and they might have a proper way of making a better operation. But if it's a microcarcinoma with a BRAF mutation, they're still going to offer active surveillance and the or the lobectomy to the patient.
Yeah, I want to reiterate. I completely agree. So we don't, the only time we get preoperative molecular testing as standard of care is for indeterminate nodules in situations where we're not sure if we're going to operate or not operate. Otherwise, if the biopsy is positive, the only time we get molecular testing is in the context of our prospective trial. And so those are patients who have maybe a 1.5, 2 centimeter thyroid nodule, completely encapsulated, no evidence of lymph node metastases, no reason to do an upfront total thyroidectomy to begin with, and the patient is equivocal as to whether or not they want a lobe or a total. We have a trial that they can potentially use molecular to decide lobe versus total based on that molecular profile. Will it help? I have no idea. And so that's why it's a prospective trial. And so hopefully we'll be getting those results in the next year or so. We're almost done with accrual. And so I'm hoping to be able to give you more information. But right now, there's no reason, if you have a positive biopsy, to get molecular testing up front. And just like Dr. Boucai, we use it for patients with advanced thyroid cancer to potentially look at targeted therapies if they're available, and potentially to decide on re-differentiation based on RAS versus BRAF versus other mutations.